Thank you, Kristen. Hello and welcome, everyone. I'm Teresa Rada, and I will be presenting the workshop for Section N medications, new item, and revisions. I'm a physical therapist with experience in direct patient care, education, and administration. My experience includes in and outpatient rehab, home health, hospice, and skilled nursing facility settings. Currently, I'm an associate at Abt Associates in Cambridge, Massachusetts. We begin with an overview of the changes to items in Section N. Section N can be found in the IRF-PAI on page 16 and in the LCDS on page 20. There is one new assessment item, that's N0415, high-risk drug classes, use and indication. And then the drug regimen review items you are already familiar with, N2001, drug regimen review, N2003, medication follow-up, and N2005, medication intervention. These items have been updated and revised to enhance clarity. Just as a reminder, this is a coding practice scenario conference. Please review the pre-recorded materials for more information about specific guidance. We are going to start with some practice scenarios and walk through the coding for the new item, N0415, high-risk drug classes, use and indication. Here is a screenshot of the item, which is used at admission and discharge. And here's our first scenario. The patient indicates that the only medication they take is diphenhydramine. This medication is documented on the order sheet with an indication for use due to seasonal allergies. And so we'll open our first poll question. Here's our poll question. So how would you code N0415, high-risk drug classes, use and indication for this patient at admission? As a reminder, for column 1 is taking, you would want to check if the patient is taking any medication in one of the listed pharmacological classes, not how it is used. And for column 2, if column 1 is checked, you would check if there's an indication noted for all the medications in that drug class. So we have A, no medications, B, check N0415Z, none of the above, C, check N0415F, antibiotic in column 1 and 2, and check N0415F, antibiotic, and N0415Z, none of the above in column 1, and leave column 2 blank. And let's see how we do. And our answer is B. None of the above would be checked in column 1. And we'll move to the next slide for our rationale. The patient indicates that they are only taking diphenhydramine and are not taking any of the medications in the high-risk drug class list. That was a warm-up. Now let's look at a different scenario with a little bit more complexity. In this scenario, during the admission assessment, a documentation review for the patient indicates that they are taking edoxaban and glipizide. The documentation also indicates the patient has type 2 diabetes and is taking glipizide to control high blood sugar. There is no indication documented for the edoxaban. So let's move to our next poll. So looking at the item, how would you code N0415 high-risk drug classes, use and indication for this patient at admission? Again, remember, column 1 is taking, and column 2 is there an indication? A is no medications would be checked. B is checked N0415E, anticoagulant, and N0415J, hypoglycemic in column 1, and then leave column 2 blank. Or C, check N0415E, anticoagulant, and N0415J, hypoglycemic in column 1 and column 2. Or D, check N0415E, anticoagulant, and N0415J, hypoglycemic in column 1 and check N0415J hypoglycemic in column 2. We'll give you a few minutes. And you can close. And 64% of you said the answer is D, and that is the correct answer. You would check N0415E, anticoagulant, and N0415J, hypoglycemic in column 1, and then check N0415J, hypoglycemic in column 2. The rationale is that the column 2 would not be checked for N0415E anticoagulant because there's no indication documented for the edoxaban. Now let's examine a scenario of discharge. In this scenario, the patient is being discharged today. The documentation indicates that they have been taking lithium and clozapine for bipolar disorder for several years and will continue to take these medications. So moving to our poll question, how would you code N0415? Would you check N0415A, antipsychotic, in column 1 and 2? Or B, no medications would be checked? C, you would check N0415A, antipsychotic, in column 1 and leave column 2 blank, or leave column 1 blank and check N0415A, antipsychotic, in column 2. I'll give you some time. Okay. Couple of seconds more and then we'll get ready to close. I think we can close. And 85% of you said A, which is the correct answer. And for those of you who do not, the rationale is that the patient's documentation for the medications they take for bipolar disorder only includes one medication, clozapine, that is listed as a high-risk drug. Therefore, only N0415A, antipsychotic, is checked. Now we are going to move on to the drug regimen review items. The following scenarios will be used to answer N2001 through N2005 as appropriate. We will start by reviewing a snapshot of each item. Here is a snapshot of N2001 drug regimen review. Then we have N2003 medication follow-up. And finally, we have N2005 medication intervention. As presented in the didactic training, Step 4 was added to the steps for assessment to enhance and provide more clarity to the guidance for this item. Potential or actual clinically significant medication issues may include, but are not limited to, medication prescribed despite documented medication allergy or prior adverse reaction, excessive or inadequate dose, adverse reactions to medication, such as a rash, ineffective drug therapy, such as an analgesic that does not reduce pain, side effects, such as potential bleeding from an anticoagulant, drug interactions, such as serious drug-to-drug, drug-to-food, or drug-to-disease interactions, duplicate therapy, such as generic name and brand name equivalent drugs that are both prescribed, wrong patient, drug, dose, route, and time errors. Additionally, potential or actual clinically significant medication may include a medication dose, frequency, route, or duration, not consistent with the patient's condition, manufacturer's instructions, or applicable standards of practice. Use of a medication without evidence of adequate indication for use. Omissions. Medications missing from a prescribed regimen, or non-adherence, both purposeful and accidental. Any of the circumstances we just reviewed must reach a level of clinical significance that warrants notification of the physician or the physician designee for orders or recommendations by midnight of the next calendar day at the latest. And any circumstance that does not require this immediate attention is not considered a potential or actual clinically significant medication issue for the purposes of the DRR items. Now we will move on to some scenarios. The following scenario will be used to code N2001, N2003, and N2005. The patient was admitted to the facility and their healthcare records were transferred from the discharging acute care hospital. The facility physician notices that the most recent medication administration record, or MAR, from the acute care hospital indicates that the patient was receiving long-acting insulin. The final discharge medication list sent with the patient does not include this medication. The scenario continues that within an hour, the physician telephones the acute care hospital and speaks to the discharging clinician, who confirms that the patient should be prescribed this medication due to their history of diabetes. The facility physician orders the long-acting insulin immediately after the telephone call with the acute care discharging clinician. No other potential clinically significant medication issues were identified during the remainder of the patient's stay. So let's go to our next poll question and take a few minutes to decide how would you code N2001 drug regimen review and N2003 medication follow-up at admission. Your choices are, you would code 0, no issues found during review for N2001, and code 1, yes, for N2003 medication follow-up. Or B, you would code no, issues found during the drug regimen review N2001, and you would code 0, no, for medication follow-up N2003. C, you would code 1, yes, issues were found during the review for N2001, and you would code 1, yes, for N2003 medication follow-up. And finally, code 1, yes, issues were found during the drug regimen review for N2001, and you would code no, code 0, no, for N2003 medication follow-up. I'll give you a few minutes to decide. You can close now. And so the correct answer is C, and 92% of you got the right answer. So it was C. You would code yes, issues were found during the drug regimen review for N2001. Let's look at the rationale. So during the drug regimen review, the facility physician identified a potential clinically significant medication issue. There was a discrepancy in medication lists that warranted notification and communication with the acute care discharging clinician or the physician designee for recommendations or orders before midnight of the next calendar day. And our rationale for N2003 medication follow-up, the answer was yes, that the identified clinically significant medication issue was resolved by midnight of the next calendar day. In this case, it was before midnight of the next calendar day. The physician followed up with the acute care discharging clinician or physician designee to resolve the discrepancy, and the physician ordered the needed medication. So how would you code N2005 medication intervention at discharge? Would it be A, code 0, no, or B, code 9, not applicable? There were no potentially clinically significant medication issues identified since admission, or patient is not taking any medications? Or C, code 1, yes. I'll give you a few minutes to decide. Okay, let's see where we're at. And if you chose C, you are correct. And let's look at our rationale. The answer is C, because the only clinically significant medication issue identified was at admission was resolved by midnight of the next calendar day, and no other potential medically significant medication issues were identified during the remainder of the patient's stay. Next, we will review a different scenario using these same items. Again, this scenario will be used to code N2001, N2003, and N2005. In this scenario, the patient is admitted to an IRF-LTAC with a recent history of a traumatic brain injury. A drug regimen review is completed by the pharmacy and identifies that the patient is on deep vein thrombosis prophylaxis and is on 2 different antipsychotic medications, one prescribed during the patient's recent acute care hospitalization, and another one newly prescribed by the admitting facility physician. The pharmacist contacts the facility physician and leaves a message providing notification of the potential duplicative drug therapy upon discovery of the issue. The scenario continues with the following morning. The facility physician discontinues one of the antipsychotic medications and notifies the nursing staff who discontinued the medication from the MR. 5 days later, the patient has a planned bedside procedure and their DVT prophylaxis is held. The following day, the facility physician noted that this medication should have been restarted earlier that morning, and the order was immediately placed. This information was then communicated to the nursing staff, and the medication was administered. No additional clinically significant issues were identified during the rest of the stay. So we'll move to our first poll question. How would you code N2001, drug regimen review, and N2003, medication follow-up? We have code 0 for N2001 and code 1 for N2003, or code 0 for N2001 and code 0 for N2003, or code 1 yes for N2001 and code 1 yes for N2003, and finally D, code 1 yes for N2001 and code 0 for N2003. And let's see our responses. And the correct answer is C. Yes, issues were found for the drug regimen review, and yes for the medication follow-up. During the drug regimen review, the pharmacist identified a potentially clinically significant medication issue. It was a duplicative drug therapy that warranted notification and communication with a physician or physician designee for recommendations or orders before midnight of the next calendar day. And for N2003, it was identified and the clinically significant medication issue was resolved by midnight of the next calendar day. In this case, the pharmacist identified the issue and followed up with the physician regarding the duplicative therapy, and the physician resolved the issue by discontinuing one of the medications and notifying the nursing staff by midnight of the next calendar day. Now we will turn our attention to discharge. So how would you code N2005, medication intervention? Our choices are code 0, no, code 9, not applicable. There were no potential clinically significant medication issues identified since admission, or patient is not taking any medications, or code 1, yes. We'll give you just a couple of seconds to put your answers in, and then we'll look. All right. And the answer is C. And 92% of you said yes. All clinically significant medication issues identified at admission and throughout the patient's stay were resolved by midnight of the next calendar day. We have one more scenario. Our final scenario, we will only use N2001 and N2003. So here we go. The patient is in severe pain on admission following their recent surgery for spinal stenosis. The patient is scheduled to receive 2 tablets of extra strength acetaminophen every 6 hours. In addition, other as needed PRN pain medications are ordered, including ibuprofen and hydrocodone acetaminophen. A drug regimen review is completed later that afternoon, which identifies that the patient is scheduled to receive the maximum dose of acetaminophen for a 24-hour period, but is also ordered hydrocodone acetaminophen PRN, which could potentially result in an acetaminophen overdose. As this scenario continues, the clinician completing the drug regimen review contacts the facility physician, who states that they will review the medication later today and make any necessary changes. So following the facility's protocol, the clinician documents their conversation with the physician. However, the physician forgets to change the order that day. 2 days later, the physician is paged to assess the patient for ongoing pain, and upon review of the patient's current medication list, sees that the hydrocodone acetaminophen was not discontinued. The physician immediately discontinues this medication and initiates an alternative PRN medication that does not contain acetaminophen. So we'll move to our poll. So how would you code N2001 and N2003? Code 0 for no issues found during the drug regimen review, and yes for medication follow-up. You would code no for issues found during drug regimen review and no for medication follow-up. Or would you code 1, yes, issues found during the drug regimen review, and code 1, yes for medication follow-up. And then code yes for issues found during the drug regimen review, and code 0 for N2003 medication follow-up. And the answer is D. Issues found during the drug regimen review, and no for N2003. And the rationale is that, yes, there was a drug regimen review using clinical judgment. The clinician identified a potentially clinically significant medication issue, which was a potential acetaminophen overdose, that warranted notification and communication with the physician or physician designee for recommendations and orders before midnight of the next calendar day. And the rationale for N2003, no, is the identified clinically significant medication issue was not resolved by midnight of the next calendar day. To close, here are just a few key insights when coding N0415. You remember to code medications according to the medication's therapeutic category and or drug classification, regardless of why the patient is taking it. And you would only code medications classified as high-risk drugs. In order to check column 2 for any high-risk medication, an indication must be provided. And here are some insights and thoughts about N2001 through N2005. A drug regimen review is performed to identify and, if possible, prevent potential clinically significant medication issues. Medication follow-up is the process of contacting a physician or physician designee to communicate the identified medication issue and addressing all physician or physician designee prescribed recommended actions by midnight of the next calendar day at the latest. And only clinically significant medication issues identified need to be resolved by midnight of the next calendar day. And thank you for your attention.